With arthritis, what can you do for it?
So we do a replacement, and replacements have evolved just like in the shoulder, like they've evolved everywhere else. One of the things that's really evolved in shoulder replacement is the stem size. All right, so we used to use.
What do you mean by stem?
So we used to use these longer stems that go down the bone, and many people are familiar with stems like with hip replacements. It goes down the bone, and then the ball sits on top of that. As we have evolved, we've made that stem shorter and shorter, and we've actually developed stemless replacements that remove less bone and are actually more accurately done, so that we can reconstruct their normal anatomy, what was there before the arthritis, much more accurately with a stemless design.
So stemless design, stemless, no stems at all, is sort of new to me. I thought you always had to brace it with a stem, and then, so show me what you're talking about.
So this is a stemless component here. So no longer do we have a stem that goes down the end of the bone here. We've got this, and it looks almost like a Mercedes-Benz sign, and it's got a lot of grit on the back side of that, and that gets pressed down into the bone here, and that we've done a long-standing FDA study that shows that the fixation here is just as good, and we don't have to go down the bone. And then once that's pressed in there, then all you have to do is put the head on top, and you're done.
Wow.
So it's much quicker in the OR, and there's less blood loss, and so it really has been a significant advantage.
So have they been doing these for a long time? Have they been doing them in Europe and the United States? What's the experience?
When we first designed this implant, we couldn't use them here in the United States until we had FDA approval, and that required an IDE study, which is a study where we have to have multiple centers around the country put them in, and then we watch them for 2 years, and then we watch those results. So after the first one's put in, it's 4 years before we can introduce it to the U.S. for public consumption. However, in Europe, we were able to put in, or they were able to put in thousands before we were able to put any in. Right now, there's probably been maybe 5,000 to 6,000 of these put in, maybe a little bit more. I don't want to overestimate it, but it's certainly at least 5,000 or 6,000 that we've put in, and we've had fantastic results.
So this is the newest and the greatest. Do you have to do that with a big incision? How do you do that one?
Well, yeah, this is done with an incision. So the incision really doesn't change with the length of the prosthesis or the materials properties of the prosthesis. We still make an incision that's on the front of the shoulder, something like this, and that allows us to get in there and open the shoulder up like a book, do the replacement, and then close it back. And then there's rehab time and downtime, about 6 weeks, where we say don't reach up over your head like this, but you're going to be able to do countertop level activities. You can type, you can write, you can use a computer. You could use a computer that night, as a matter of fact. So we put anesthetic in the shoulder when we get done, and then that night people are able to take the sling off and actually use a computer if they want, or use it to eat with.
So this is the newest. It's easier. You don't have a stem. The recovery time is obviously much quicker. When can you go hiking and pulling up on something and reaching up on a ladder and doing the things that we want our shoulders to do?
About 3 or 4 months out. So the first 6 weeks we're letting everything heal, and then we work on strengthening exercises for a second 6 to 8 weeks. That's kind of like the second phase. By 3 or 4 months, I'm letting them play golf, letting them swim. You'll still get improvements in your function, in your range of motion, in the things you want to do for at least a year, and some studies even 2 years.